Okay, so far so good. We're going to hopefully get through the second part of this and finish up Unit 5. We're picking up where we left off in Chapter 47 through the silly slide in here on LDL stands for lousy darn lippos and HL stands for hunky-dory lippos. I tell people it's your L is your lousy cholesterol that you want lower, and your HDL is your healthy heart cholesterol that you want higher. This was cute. Potato chips aren't rubbery and blubbery like fat. They're crispy and crunchy like lettuce. That proves they're diet foods. Just cute. Okay, so that's a good way to enter into our lipid lowering. This is just a kind of busy picture talking about the different kinds and where they work. We are going to cover these multiple kinds and explain them, so don't worry about reading this whole beginning in this chapter. I want you to go right to your bile acid sequestrants on page 810. Okay, so let's look at, you have a table on page 812, 47.3, your bile acid sequestrants, your cholestyramine. Even if you were to get your cholestyramine or whatever on the Kaplan or the NCLEX, cholesterol, cholesty, they're biosequestrants. They are in a powder form. You're going to have to drink them with a lot of water, and you mix it in a drink or a non-carbonated liquid, usually water. It blocks a lot of absorption, so you have to be real careful with your fat-soluble vitamins, which are A, D, and K. So you're watching for one of the major side effects is watching for bleeding, because if it's blocking your vitamin K absorption, vitamin K is needed for clotting. It's contraindicated if you're allergic. I told you the fat-soluble vitamins, which of course then makes it totally contraindicated for pregnancy because of those vitamins that are being blocked. Don't worry about this. Let's see. Lowers your LDL. Don't worry about it. Drug interactions with warfarin, because of course warfarin is with your clotting, and it blocks your warfarin, thiazide, and beta blockers all get blocked from absorption along with your fat-soluble vitamins. Adverse effects are your GI distress and constipation. You look at your nursing considerations in 814. Always teach lifestyle changes for all the blood pressure and the cholesterol medicine, so I'm not going to keep repeating that. Mixing with lots of fluid. Take the drug before the meals to ensure the drug is in the GI tract with the food. Administer all other oral medications an hour before or 4 to 6 hours after you take the bile acid sequestrant. Move on to your next class, which are your statins. Your HMG-CoA reductase inhibitors are often called your statins, because if you look back on your table, it's 47.3 on page 812, you will see all of them: atorvastatin, fluvastatin, lovastatin, pravastatin, all statins. So they're often referred to as the statins. They work in your liver. They are your first line preferred. If they can be tolerated, they are your preferred treatment for high cholesterol. Your cholesterol is formed in your liver, mostly at night. Your AST and ALT, your liver enzymes, are very active at night, so preferable to take these in the evening. Big side effects are elevation of your liver enzymes, which is your AST and ALT, so you're watching them, and you're watching for muscle toxicity. So your CK enzymes, creatine kinase, is released with muscle damage, and those it can be they're really strong, big, so they clog your kidneys. Rhabdomyolysis leads to the kidney damage and Coca-Cola urine. I just thought this was cheap. My heart will go on as long as I am on my Lipitor. Let me see, what else do I need you to know on those? Those muscle aches. Atorvastatin prototype is on page 817. On your teaching, of course, your lifestyle, muscle aches, reporting liver enzymes, and that is it. Of course, if they already have liver damage, they're not going to be able to take a statin. Next class down is your ezetimibe. This is new cholesterol, but obviously, if you can see the bottom, that's an old slide I found from 2001. Going back to your table, now on page 813, it's the only one in its class, and it does exactly that. It blocks the cholesterol absorption. The prototype is on the bottom of page 819. Don't worry about that too much. Watching for dizziness. Targets intestinal absorption and dietary and biliary cholesterol. So if they have a bile duct blockage, it is contraindicated. It's also, where is it? Contraindicated. All of these are contraindicated in pregnancy or lactation. If you have to give anything, it would be the cholestyramine, the bile acids, or sequestrant, if benefit outweighs the risk. If you have to give one, that's the only one that's safe in pregnancy and lactation. The rest are contraindicated. It inhibits that cholesterol absorption, so adverse effects: headache, dizziness, fatigue, upper respiratory infection, muscle aches and pains, bloating, diarrhea. Do not risk of elevated serum ezetimibe increases if you're giving it with a different phenofibrate or cholestyramine, or antacid, so you try to not put those together, and give it 2 to 4 hours apart from administering any other drugs. And let's keep moving here. That's all you need to know there. Then we're going to go into your fibrates, which starts on page 821. If you go back to your table on page 813, I want you to focus on that third one, gemfibrozil. But if you look at all the names, there's phenofibrate, phenofibric, gemfibrozil, FIBR, fiber is in all your fibrates. That's how you can remember them. That's how I remember them. So your fibrates inhibit triglyceride synthesis, so they're used mostly for the elevated triglycerides, sometimes in combination with some of the other anti-lipidemias drugs. It has been approved to give phenofibric acid with a statin, or by itself if it's just to treat the elevated triglycerides. It is metabolized in the liver, so you are monitoring your liver enzymes. You're watching. Use caution if they have renal impairment. Common adverse effects, same as the others: the headache, the back pain, the nausea, the diarrhea, and muscle pain. So all other than cholesterols can cause these problems. Some people get gallstones with this, so you're watching for that problem there. Anything else? All of these drugs, whatever I've mentioned, any drug, when almost everything has been contraindicated in pregnancy, so you're making sure if they're childbearing age that they're using, they're on birth control, that you're doing a pregnancy test, that they're not pregnant, and often suggesting they use a secondary barrier just to make sure that they don't get pregnant. Watching for central nervous system symptoms in any of these cholesterol medicines. Last one here is your vitamin B, niacin or niaspan. It's mentioned on page 821, just a little blurb there. That flushing is the major side effect, real red and flushing, very common. Many people, it subsides within the first couple weeks. Some people it's so intense they can't stand it. Some people it never gets better. Best thing, I put the little picture of the aspirin, low dose 81 milligram aspirin with the niacin, with a low fat snack at night to decrease these problems. And again, because your liver is producing all these cholesterol at at night, that is the best time to take it. It can increase your good cholesterol, your HDL, and decrease your triglycerides. Other than the flushing, they can get nausea and abdominal pain. And that is it. And that is all I want you to know in this chapter. I want you to move right on into chapter 48 on anticoagulants, antiplatelets, and thrombolytics. Go straight to page 830, table 48.1. There's a few we will focus on here, but first I want you to flip on over to page 832, box 48.2, herbs and alternative therapies. There are several that are naturally, these herbs will cause, have an anticoagulant effect, so they increase your bleeding, decrease your coagulation, and so they have to use caution. They cannot take these herbs when they are on any anticoagulant medication. So I've found a thing that talked about the 4 G's, your ginger, your ginkgo, your garlic, and your green tea. So those are 4 G's: ginger, ginkgo, garlic, green tea, and also add in there your chamomile. Those are the ones I want you to remember that are contraindicated with your anticoagulants. Okay, we're going to move into your clopidogrel, which is your Plavix, on table 48.1 on your antiplatelets. Aspirin, of course, decrease your platelets. And then you have your clopidogrel or Plavix here. Also notice your dipyrimidomol or persantine. I always tell people it makes the platelets kind of, with your clopidogrel and your dipyridamine, that they just make the platelets kind of slippery. So this picture is really good here. It says when platelets gather together, use Plavix for crowd control because they will not aggregate. They will not group together. So it prevents that aggregation or grouping and makes them slippery. So it works very effectively. Here, watch for skin disorders, upper respiratory infections, flu-like symptoms. Caution with hypertension, hepatic and renal dysfunction problems, and your history of bleeding. You're going to do platelet counts when you're on clopidogrel or Plavix. I don't think they gave us a prototype. They just did a prototype on aspirin for some reason here. No adequate studies of these drugs in pregnancy, but they're contraindicated because of potential for bleeding. Contraindicated during lactation also. And monitoring your platelet count. Anything else? I think that's it on that one. Now we're getting to get your heparin and warfarin, which is also in your table. Under your anticoagulants on 831, heparin and warfarin. Warfarin is Coumadin. So your heparin is your IV or sub-Q, and it's to prevent clotting, used for if they have a pulmonary embolus, prevention of pulmonary embolus. Your warfarin or Coumadin is a pill form. Often they will start on a heparin, and while they heparin and warfarin or Coumadin together, while they're waiting for their warfarin levels to become therapeutic, they'll have the IV heparin. Once the warfarin is therapeutic, they'll stop the heparin. Heparin is very, very, very short acting and can lead to major bleeding issues, so it's only given in the hospital because it's IV or sub-Q. Your heparin is monitored with your PTT. Your warfarin is monitored with your INR. And I will mention again a little bit your antidotes. Your heparin antidote is protamine sulfate. Your warfarin or Coumadin antidote is vitamin K. This slide goes more into your heparin. I inhibit the clotting time as I leave your system, convert faster. Heparin controls, helps to control, prevent deep vein thrombosis, pulmonary embolism, and DIC. It doesn't break or kill the clot, it just delays them from forming. It doesn't stop it once the clot is there. You're going to watch for spontaneous bleeding starting in the mucous membranes, rectal, oral, nasal. You watch for bleeding in the urine, everywhere. Ecchymosis. You're monitoring their PTT or prothrombin. They have a normal control, and your therapeutic is 1.5 to 2 times the control is a therapeutic level. Your heparin. We go on to your warfarin or your Coumadin. You're monitoring your PT and INR, which is a ratio. I like this. Hey, Mr. Coumadin, can vitamin K come out to play? Not as long as I'm in the neighborhood, because the warfarin or Coumadin blocks your vitamin K. So your antidote, if your clotting time is too high, is vitamin K, because that's how it works, is blocking your vitamin K. An overdose of Coumadin can cause hemorrhage, headache, bruising, back pain. Coumadin is used to prevent clot formation. Again, it also doesn't lyse them. It's uses the same way as your heparin, but it's an oral form, can be longer term use because it blocks your vitamin K. You don't want to eat a lot of foods high in vitamin K, such as your dark green vegetables. These were just 2 other things. It gives you labs to know. Normal PT time is 10 to 13 seconds, so you want your therapeutic range is 2 to 3, or I say 2 to 2.5 times your control. So if your control is 10 and your lab value now is 40, you're way higher than 2.5 times the control, so you're too high. Not therapeutic. Therapeutic, if your control was 10, your therapeutic would be like 2.5, so 25, 30. PTT is your heparin. Control range is somewhere in 30 to 50. And again, therapeutic is about 2 to 2.5 times your control. And last slide here on this talks a little on your low molecular weight heparin, which Lovenox is one example of that. Enoxapril is the generic name. It's predictable, less bleeding chances, don't have to do any lab work. It can be self-administered at home with sub-Q injections once or twice a day. What else do I want you to know on your anticoagulants? Just watching for bleeding. You know, we have new drugs like Xarelto out now. That's less chance of bleedings. You got your drugs, Safe Drug Administration, which is simply your vitamin K is your antidote, or for your warfarin, and your protamine sulfate, which is your antidote for your heparin. Contraindicated in pregnancy. Wait. Warfarin is contraindicated in pregnancy. If you need an anticoagulant in pregnancy, you will give heparin, because the Coumadin warfarin is contraindicated. So if you need an anticoagulant in pregnancy, you use heparin. If you need an anticoagulant and you're lactating, you will use warfarin. Okay. Vitamin K, I talked about that. Protamine sulfate foods. I think that's it there. We're going to go on to your next slide, which is your thrombolytics, which starts on page 841. The only one I need you to pay attention to is your urokinase. If you look at the name, thrombolytic, clot lyse, breaking up the clot. Where the anticoagulants don't break the clot, they prevent clot formation. Your thrombolytics break clots. So urokinase is used to break up a clot that is already formed. You've got a clogged artery, just run this IV. It's only given IV. It's very, very short time to break up the clot and stop. They work extremely well. You have to put them on a pump. Watch for allergic reaction, spontaneous bleeding, oozing from any fresh wound site. I've seen bleeding into the urine around IV sites. You can bleed into the brain, so you're watching for CNS changes, central nervous system changes. You use sometimes with the heart attack, ischemic stroke, pulmonary embolus, opening up catheters, intravenous catheters. The biggest thing is watching for your bleeding. You will learn more about those drugs when you get into the critical care course, so here's just all I need you to look at. Here on your antihemolytics, page 845, don't even need you to look at the names, just know for somebody that has, it's to treat hemophilias, and say this child has learned to do self-administration. Those drugs are always given intravenously. That's all you need to know on those. Skip right along into chapter 49, your anti-anemic drugs. I'm not covering much at all in these. Your erythropoietin, which is mentioned on page 854. Erythropoiesis-stimulating agents. Erythropoietin is made in your kidneys to stimulate the production of red blood cells. When you have chronic renal disease, you don't form the erythropoietin, so they administer intravenous or during dialysis erythropoietin to stimulate that red blood cell formation. That's all you need to know there. Skip along into, let's see, patients receiving erythropoietin on your nursing considerations on 857. CV, cardiovascular effects, monitoring the pulse and their blood pressure, inspecting lower extremities for edema, which might be a sign that there's some cardiovascular deficits or changes happening. Then your page 856, agents for iron deficiency anemia. You have table 49.2 on page 859. Your ferrous gluconate or your ferrous sulfate or your oral forms. Further down, your iron dextran, which can be given IM or IV. If it's given IV, it's treated just like a blood transfusion. If it's given IM, it must be given Z-Track. You don't know if you learn Z-Track, it just can be corrosive and painful, so you give it a Z-Track to prevent the medicine from coming back through that track. You do that zigzag. What else? Oral ferrous sulfate, iron. You can get toxic with iron, so it is important not to have iron if you are not iron deficient. People just don't need to take it because they think they're tired. Also, liquid forms for children, it will stain the teeth, so always give it through a straw. Iron absorption is very difficult, so you want to give it with a vitamin C or orange juice or something to help with absorption. You do not give it with milk products because that blocks absorption. Let me see, I think it has listed your other things. Administer oral forms with meals that do not include eggs, milk, coffee, or tea, because all of those will impair it. I said iron, you're giving Z-Track. That's it there. And then your megaplastic anemias, you have your folic acid and B12. I always say you have iron deficiency anemia or you have vitamin deficiency anemias. So it should be B12 and your folic acid, B12. You can give oral, or mostly it's a B12 injections. Folic acid is given several different routes, but I'm not going to ask you on those. We're going to move right into your next chapter, chapter 51. Believe it or not, 2 chapters left. We're skipping right past chapter 50, right into 51. Go straight over to page 884, table 51.1. The first are your thiazide diuretics. Your main one is hydrochlorothiazide or HCTZ. It can be given to adults and children. We mentioned it with your antihypertensives, given alone or in combination. contraindications to thiazide is being allergic to sulfa drugs. So if you're allergic to sulfur, you cannot take hydrochlorothiazide. It's also contraindicated if renal failure. It can worsen your glucose levels for the diabetic, so extreme caution if you're giving it to a diabetic. It is not potassium sparing, so it is in this Lupahenley. It's not as potent as the loop diuretics, but it does cause some loss of potassium. So sometimes they will give it in combination with an ACE inhibitor, where ACE inhibitors can increase the potassium, hydrochlorothiazide can decrease, so the combination can sometimes work out very well. What else did I want to tell you of these? Anything else? I think that's it on your hydrochlorothiazide. So your next group is, if you look at table 51.1, skip your thiazide-like diuretic, go right to loop diuretics. You see bumetidine or Bumax, and then the next one, furosemide or Lasix. I want you to focus on your furosemide or Lasix. But remember, bumetidine and furosemide for this exam, furosemide or furosemide, that I don't know which one Kaplan and Klex will throw at you. I'm focused on furosemide. It can be given orally or IV, of course decreasing your dose in the geriatric population. There are very loop diuretics work here in the Lupahenley. You see all of these electrolytes that are absorbed in the loop. So if you're given this potent diuretic that works in this loop, you're losing all these electrolytes, especially your potassium. So hypokalemia is a huge risk with loop diuretic. Loop diuretics start the discussion on page 889. Because they are so potent, they're great for congestive heart failure and pulling those fluids off. You're watching for hypotension and hypokalemia because of the potency of these drugs. Adverse effects, page 892, definitely your hypokalemia is very common. Alkalosis or rise in your pH. You can lose calcium. That's why you get the tubules along with your bicarbonate, leading to that alkalosis. Long-term use of them can result in hyper or elevated blood glucose levels. Ototoxicity, which is problems with your hearing, can result from long-term or higher doses of your furosemide. Your next one is, go back to my table. Skip the next group, go down to your potassium-sparing diuretics on page 885 on your table, spiralactone or aldactone. Also potassium-sparing diuretics, the dialogue begins on page 893. They retain your potassium rather than losing it. Aldactone or spiralactone, your prototype is on page 894. Just remember that it holds on to your potassium, so you're actually monitoring potassium. You would not want to give this with a drug like an ACE inhibitor, because an ACE inhibitor also can increase your potassium levels. Hyperkalemia is just as dangerous as hypokalemia. Your last one is your osmotic diuretics on the bottom of page 894, or the last group listed on your table on page 895. The only one in its class is mannitol. So as you can see from your prototype, a mannitol on the bottom page 894, it is used for increased intracranial pressure, cerebral edema, to pull that off the brain. It's usually often, it will be used in combination with a loop diuretic. That's all you need to know on that one. And believe it or not, we are moving right in to chapter 52, the last chapter of this unit, on page 901, urinary tract anti-infectives. The only one in table 52.2 that I want you to focus on is your nitrofurantoin. It only lists the nitrofurantoin here, which is 4 times a day. You can also see it as macrobid, which is the same drug, brand name, twice a day, because people aren't going to take a drug 4 times a day. I usually prescribe macrobid because it's twice a day. It works on certain bacteria, so it can either have, as you see here, it can be bacteriostatic or bactericidal, depending on which bug it is. It's rapidly absorbed. It's excreted 50% active drug in the urine. That's why it works so beautifully for the urine. It is only used for urinary tract infections. Works best if the pH is very low. Because it only works in the urine, people are really good about not finishing antibiotics, keeping some around, and if they think they're sick, they'll start an antibiotic. Well, if they're going to hang on to their macrobid, it's not going to work on any other infection other than the urine. Adverse effects, very common headache. They put in bold because it is very common to have a headache with it. Anorexia, GI disturbance, mostly the headaches. Let's see. Anything else I want you to know on nitrofurantoin? No, that's all I want you to know on it. And then your phenazopyridine or pyridium or azo, it's been called, is over on page 909, table 524. Azo standard, pyridium, it's over the counter as azo. It's a urinary tract analgesic. Often you will see these two together. If somebody is having real dysuria, painful urination, we'll get pyridium along with the antibiotic. The pyridium or phenazopyridine is only given for a couple of days for that burning, difficult, painful. Some people will take azo over the counter. They'll buy it. It's been marketed that way, and they take it because they think they have a UTI, which often they do. They take the azo, it's feeling a little better. They take it a couple of days, and the pain is still there, or their other symptoms like tenderness are still there because it's only helping with that burning because it's an analgesic, but it is not killing the bug, which it's marketed improperly. It also churns your urine orange, an orange-red color. So if it's prescribed, you need to warn them that it does this orange-red color. It also messes up your urine dip, so if you go to the doctor and they've taken azo, you have to send the urine off because it messes it up and you can't get a true reading. So for symptomatic relief, headache, rash, yellow tinge to the skin or sclera, which is temporary, and some GI disturbances, it's contraindicated when there's severe renal impairment. That's all you need to know on those. And then we go to the antispasmodics, table 52.3 on page 906. The only one to focus on there is your oxybutynin, or Ditropan is a common generic. You have brand name. Your prototype is on page 907. I thought this picture was good to help you think of antispasmodics. You'll think of your oxybutynin, male or female. So the best picture I found of oxybutynin was this. Even though it shows a female, this picture tells you it can be male or female for that overactive bladder or difficulty emptying the bladder completely. They will give this. It is an anticholinergic. Now, if you remember, your cholinergic, rest or digest. So if it's an anticholinergic, if it blocks that cholinergic effect, it does the opposite. So you can anticipate what your side effects will be. If it does the opposite, you're going to have the dry mouth. Remember, I can't see, I can't eat, I can't pee. So you have nausea, decreased appetite, dry mouth, blurred vision, urinary hesitancy. They also may have drowsiness and dizziness and inability to sweat, decreased sweating, so you don't want to be on oxybutynin and be out in the heat because it's an anticholinergic. Your last one, your alpha-1 blocker, which is on page 9, 12. These are your drugs to treat benign prostatic hyperplasia, or BPH. They work by inhibiting the contraction of the bladder. So remember that about it, inhibiting the contraction of the bladder by relaxing everything. Table 52.5 on page 613. 913, focus on your tamsulosin or Flomax. If you notice, most of these have the Zosyn end. If you remember the pictures we did on earlier units, it has many uses. We're focusing simply on the BPH effectiveness of it, side effects, nasal congestion, and hypotension. And that's all you need to know on this. And we made it to the end. Study pharmacology. Are you serious? It's like memorizing a dictionary. I tried to simplify for you. Please stick to exactly what I told you. This is the end of Unit 5 and everything you need for this Unit 5 exam.